Thank you for the introduction, and I'm happy to see so many people here on this meeting. I agreed with Professor Fotopoulou that she would discuss the preoperative examinations and which type of surgeon and surgery based on the findings on the imaging. I will more concentrate on criteria for neoadjuvant chemotherapy or primary debulking. What about secondary debulking? What do we do there? And then on the importance of centralization, because I think characterizing a tumor correctly will lead to a correct diagnosis, but also a correct treatment, operation and postoperative treatment of patients with ovarian cancer. For me, it started with this study, which was quoted already by Christina, which we published in the New England Journal, where we randomized patients to neoadjuvant chemotherapy or primary debulking. I will not go into details of the study itself, but will concentrate on what the conclusions in practice are, how we select patients for primary debulking or neoadjuvant chemotherapy, and we will certainly discuss that later on today as well, during the discussion this afternoon. I think most of you know that the overall finding, and the same is then later confirmed in the CHORUS trial in the UK, even though this trial is quite different from this one, but I will not go into detail there in this comparison. But the survival was the same whether we gave in stage 3C and 4, and I have to stress that, neoadjuvant chemotherapy or primary debulking. Some subgroup studies or subgroup analyses, which are not in the paper but in the supplement of the New England Journal, is, for instance, this one. The first here, you see that the top curve is the patients who are primary debulked to optimal residual disease, and optimal, according to the current definition, is not less than 1 centimeter but no residual tumor, that they have the best survival at 3 years. But that's only 19% of the patients. And the second group is those who have neoadjuvant chemotherapy and then interval debulking, and that constitutes 51% of the patients. And indeed, they have a little bit less prognosis, but they are the second best, and they constitute 51% of the patients. And this confirms again that these patients, as you have 51% versus 90%, is obviously the group with more tumor at the start, which is included in this group without residual tumor. And then comes the group with suboptimal, which means 1 to 10 millimeter, which is confirmed in many studies to be worse at primary debulking than no residual tumor. And then I think it's also important to realize that, for instance, the group with neoadjuvant chemotherapy suboptimal, so leaving, for instance, 1 or 2 millimeter, is together with those with more than 1 centimeter is exactly the same. So at interval debulking, you should have no residual tumor. And as Christina also mentioned, in the multivariate analysis, no residual tumor was already proven, for instance, by the study of Dubois and Bristow, to be the most important prognostic factor, but in this study we proved the same to be true at interval debulking. So also at interval debulking you should certainly have no residual tumor. Let's go a little bit deeper into this slide, and then I will come to the topic why I think your imaging is so important. What we split here is the patients randomized to primary debulking and receiving a primary debulking, which is the red line. And those where at primary debulking the surgeon said she's not operable, we will give neoadjuvant chemotherapy and then do an interval debulking. That's the blue line. And the green line is the patients randomized to interval debulking after neoadjuvant chemotherapy. And what we see is that we lose about 10% of the patients the first 6-8 weeks in those where we do primary debulking in this randomized study. And this points to the very important point that selection of patients for primary debulking or for neoadjuvant chemotherapy is of utmost importance, and their imaging be it diagnosing on ultrasound that it's a malignant tumor, or diagnosing exactly what the tumor load is prior to surgery is of utmost importance. And in this I disagree with Christina, because I think as good as possible imaging prior to surgery is very important to avoid doing unnecessary surgery or surgery which leads to postoperative mortality, which was 3% in the primary debulking arm, or hospitalization at intensive care due to complication, which leads to the other 7% we lose due to complications and not being able to give chemotherapy postoperatively. So how can we select these patients? So what this analysis showed, and what we plan to do also with the CHORUS trial, is to do a subgroup analysis and to look, for instance, on stage 4. And in this stage 4 disease, you see that the survival is significantly better if you do neoadjuvant chemotherapy. So just doing ultrasound, to me, and then opening up a patient is, to me, really of the 70s and the 80s, and you should not do that, in my opinion. You should select a patient with stage 4 and give them neoadjuvant chemotherapy. That's not the end of the story, I think. The opposite is also true. Keep in mind, we only randomized stage 3 and 4 based on CT at that time, so big stage 3s and 4s. But still, if you select a group of patients who have tumors which are smaller than 5 centimeters, not the tumors, but the metastasis, is smaller than 5 centimeters, these patients significantly do better with primary debulking. So you should know that before you're doing the operation. How much spread do you have in the abdomen? And it's not because I published on neoadjuvant chemotherapy that all patients get here neoadjuvant chemotherapy. On the contrary, I think. But we try to select the patients based on good imaging. I think after 20 debates with Professor Dubois, we were so fond of it. No, we didn't like it anymore, and we wrote a paper and described on what we agreed and disagreed. That's published now 2 years ago in Gynecologic Oncology as an editorial. So the first thing you should know, and I will come back to that when I talk about centralization of ovarian cancer surgery, do you have the surgical skills and resources? Do you have time and persons who know how to do a debulking surgery? If you don't, do not abuse neoadjuvant chemotherapy. I think this is completely wrong, and what I see in many countries, and it's also in Belgium, is that neoadjuvant chemotherapy is abused because they think it's an advanced disease, or because they don't have time or the surgeon to do the correct surgery. 25% of the patients have a stage 1A or 2A. Of course, they must be operated. 75% have 2B to 4, of which 25% 2B to 3B, and 50% 3C to 4. So we must know that before the operation, because, of course, 2Bs and 3Bs must have upfront debulking. What about the remaining 50% of ovarian cancers, which is 3C and 4? Well, both in Essen, where there is also a very aggressive surgeon, but I think Leuven is also aggressive, but in a different way and in different timing. 5% we judge, both in their series and our series, to be not fit enough for radical surgery. 85, 90 years old, stage 3 CT4, they get neoadjuvant chemotherapy, both in Germany, in Essen, and in Leuven. That's the same. Of the remaining 45% in our series, which was based on more than 500 cases in both institutions, 12% had 3C, but extra-abdominal metastasis less than 5 centimeters. And we both believe that these patients are better off with upfront debulking in the majority of cases, but I will go into detail about that. Then the difference is in the remaining 1/3 of the ovarian cancer patients were based on anatomical definitions, which I will show. We decide in 25% of the 33 to neoadjuvant and then interval debulking, while this is only 8% in Essen. Of those who get neoadjuvant chemotherapy, 2 to 3%, both in Essen and in Leuven, are progressive on chemotherapy, usually mucinous tumors, and these do not get interval debulking, while the remaining majority in Leuven gets interval debulking, 25% of the total of ovarian cancer patients, while only 5% in Essen. Now, what are the criteria here in Leuven for neoadjuvant chemotherapy? The first thing I want to say to an audience that is interested in diagnosis is that I, and also in Essen, believe that we should have a biopsy whenever possible. We should not start neoadjuvant chemotherapy based on cytology alone. So biopsy proven epithelial ovarian or fallopian tube or peritoneal cancer. In the UTC study, we allowed cytology, but I've added only if the patient is in a too poor condition to undergo an image-guided core biopsy or a laparoscopy. And in the UTC study, we indeed accepted, but had some 3% of non-ovarian cancer patients randomized. So that was not the purpose. So that's here we had the fine needle aspiration showing carcinoma, a suspicious pelvic mass, CA1 to 5 CEA ratio above 25, and negative gastroscopy, colonoscopy, and mammography. If you have all that, you only have 3% of other tumors, but still you have 3% of patients that you should treat in another way. So with the current imaging and core-guided biopsies, I think if you can't do a laparoscopy, you should at least be able to do a core biopsy to prove it's an ovarian cancer before you start neoadjuvant chemotherapy. Then, like Christina also mentioned, infiltration of the superior mesenteric artery, diffuse and confluent carcinomatosis, like Christina showed a beautiful case of a bowel full of tumor. This, if you want to resect that, you would have to resect at least 1 meter of small bowel. This is for us an indication for neoadjuvant chemotherapy. Intrahepatic metastasis, as also mentioned by Christina. Infiltration of the pancreas, according to Professor Dubois, he still operates it. We did that for 20 years, but we stopped that after the EOTC trial because we think these patients with infiltration of the pancreas, duodenum, or the hepatoduodenal ligament or metastasis on the backside of the porta hepatis, not the anterior side. The anterior side we operate, but not on the backside. So again, imaging is here important. Extra-abdominal disease is important to detect, as you will see this afternoon in the presentation of Professor Van der Caveye. In our material here in Leuven, we have now 38% stage 4, because our imaging is so much better than in the past. But some stage 4s, we do primary debulking. For instance, inguinal nodes, of course, are stage 4 extra-abdominal, but we resect them, of course. Retrocrural, solitary or pericardic nodes, if this is the only reason to be stage 4, we don't think this patient is inoperable. And of course, pleural fluid, the 4A, the new 4A, is not a contraindication for primary surgery if there is no tumor on the pleura. And then what also was mentioned already, impaired performance status or the inability to give blood transfusion, for instance, Jehovah Witnesses, sometimes we choose neoadjuvant if the surgery would be very extensive. So the criteria for interval debulking is no progressive disease, and in case of extra-abdominal disease, it should have disappeared with the chemotherapy or should have become resectable. And again, a performance status allowing maximum surgical effort. So how to select these patients? Christina already mentioned it, and you can have CA1 to 5, imaging, PET-CT, we did even CT peritoneography to see the tumor on the bowel better, microarrays has also been shown already. Well, all these criteria are simply not good enough. For instance, that's one of the figures in one of these papers saying that this patient is inoperable because she has a paraortic node close to the renal vein. Well, in my mind, this patient is clearly operable. So the message is you should in your institution, people who are doing imaging should agree with the surgeons or the gynecological oncologist what is operable and inoperable. And that's what Van de Cave will show you this afternoon. We have agreed and published what we think is inoperable primarily, and he has to tell, based on MRI, whether it's operable or not, according to him, and then we've done the operation. Now in more than 300 primary cases, and you'll see the results later on. So that's an example. What he will show is not a simple MRI, but an MRI whole body, as we call it, as you see here, with both T2 and diffusion. Diffusion is very important, and we compared this also with PET-CT, for instance. You see here the diaphragmatic metastasis, the metastasis on the stomach, the combination of diffusion and T2 showing the tumor on the sigmoid and so on, but he will certainly explain that. I don't have time to go into that, but what I want to tell you is that for us, whole body diffusion MRI is a very promising imaging tool to see, according to these criteria I've shown, to predict tumor burden, not only in the abdomen and extra-abdominally, but for instance also on the bowel, which is completely different from PET-CT. Small metastasis from 2 to 3 millimeter on the bowel, he can see, and we have confirmed that. And in our experience in selected cases, together with image-guided core biopsy, we are doing less laparoscopies based on these better imaging than we had in the past. But we will discuss that in the afternoon. Second point is criteria for secondary debulking. We will also ask people who are doing imaging, ultrasound, and other imaging, can we operate this patient? What is the current state of knowledge now? It's the same as primary debulking. The more you do in R0 resection, the better the survival. There are many papers. This one is a meta-analysis of Bristow, but there is another meta-analysis of Zhang in the British Journal of Cancer, where you see exactly the same as at primary debulking. Can you remove everything? Then the survival is substantially better than if you can remove up to 1 to 10 millimeter or less. So it's quite comparable. We just finished the AGO study, which is also an NGOT study, OV20, where patients with platinum-sensitive relapse were randomized to secondary debulking or not. And it's not a coincidence, I think, that the two largest centers are the center from Christina Vergote earlier, Berlin, and then second came Leuven. And I mentioned that not because I'm proud of these figures, but also because I want to show that, again, imaging will show you different things in this trial, I think. What are the criteria? The criteria in desktop is how can we predict a complete resection? Not what is the survival. Complete resection is the purpose of this algorithm. And what does it include? Very easy. A good performance status, no residual tumor at primary surgery, and absence of ascites. It's very easy. And what do you know, both on the desktop 2, which we also were part of, and desktop 3, is that a positive desktop score predicts complete resection in 2 out of 3. The question is, am I happy with 2 out of 3 to do 1 in 3 a laparotomy, which doesn't make sense. Let's go back to the meta-analysis of Zhang of more than 1,000 secondary debulkings. Are these 3 criteria enough? Well, in my mind, not. One important factor is the platinum-free interval, more or less than 23 months. Ascites is in the score. The extent of the recurrent disease is important in this score, and of Zhang. And, of course, residual tumor after the secondary debulking, which obviously is an important prognostic factor. So what about extent of disease and the platinum-free interval, which are important for predicting survival? I think these should be added when you select patients for secondary debulking, the spread of the disease and the time to relapse. Better imaging, I think, again with ultrasound, but also again with MRI diffusion or PET-CT if you don't have diffusion. MRI might improve the prediction of R0. And I must admit that in Leuven, we randomized only patients who had a positive desktop score, but also who fulfilled the criteria which I explained for the primary debulking. So it's a selection of cases, because obviously when I see on the MRI diffusion a clear infiltration in the mesenteric root around the superior mesenteric artery, we did not randomize these patients. The question is then, what about open laparoscopy? We have done a lot of laparoscopies, and the Italians have also published on that, and we started that 22 years ago. Do we use that for selecting patients for secondary debulking or not? Well, we do that, but much less than in primary debulking selection, because we already have a biopsy, so we have a diagnosis. And two, we have a lot of these patients have adhesions, which makes it very difficult to see the spread intra-abdominally, and this increases, of course, also the risk of laparoscopy and going into the bowel when you do the laparoscopy. So we are not doing a lot of open laparoscopies at recurrence, but we are still doing at the primary cases if we don't have enough information based on MRI imaging. Then the last point is importance of centralization of ovarian cancer surgery, which I wanted to discuss as final step. There is a Cochrane analysis, and this shows that meta-analysis of 3 studies in more than 9,000 patients, institutions with gynecologic oncologists on site, prolong overall survival in patients compared to community or general hospitals. So that's the first point. I think your imaging is important to guide the correct patients to the correct place and gynecologic oncologist. We are not interested in operating benign cysts, and that's a waste of time. And probably we do it in a bad way, because we are a gynecologic oncologist. We are probably not as good as a general gynecologist in operating benign cysts. Another analysis of the Cochrane on patients over 50,000 women showed that teaching centers or regional cancer centers prolonged survival in women with gynecological cancer compared to community and general hospitals. It's always very tricky to say that, and I know I'm not making myself popular towards some general gynecologists, but I think it's my duty to draw the attention that ovarian cancer surgery is the most difficult surgery we have in gynecology, I think, and that this type of cases, especially advanced ovarian cancer, must come in the hands of and the places where there is most experience. We did an analysis on behalf of ERTC and ESGO and came to the conclusion that less of 50% of European patients with ovarian cancers are treated according to protocols and are benefiting from the minimum required surgery. USA, similar. 13,000 patients analyzed. Adherence to the NCCN guidelines improves 5-year overall survival by 30%, but the experienced hospitals, meaning more than 20 cases per year, treat only 18% of the patients. Low volume hospitals treat in the US 71% of the cases. Another analysis by Bristol, 45,000 patients analyzed, where in centers where they do more than 35 debulkings per year, the survival is significantly better than if they operate or do debulkings between 9 and 20 or less than 9 cases per year. So the threshold, which is generally accepted and which is also recommended by the Belgian authorities, is 20 debulkings per year. But what did we see in Belgium? Like in the US, only 17% are treated of ovarian cancers in centers with more than 20 cases per year, and 70% of the hospitals treat less than 5 cases per year. So there's still a lot of work to do, and I repeat that because I think that people interested in imaging can play a central role into that. Because centralization of large volume ovarian cancer centers improves survival. In almost all EU countries, including Belgium, the majority of the patients with ovarian cancer are not treated in centers with more than 20 cases per year. And I think better imaging, ultrasound of course, but not only ultrasound, can improve the correct referral of patients with advanced ovarian cancer for debulking surgery and hence improve survival. And that is why I think the achievements of IOTA and this IOTA meeting are of paramount importance. I thank you for your attention.
Thank you, Professor Vergote. Any questions? Daniela Fischerova.
Thank you for a wonderful lecture. I would like to ask you if you select the patients to neoadjuvant chemotherapy on the size of the largest extra-ovarian metastatic lesion being more than 5 centimeters, do you also include the size in omentum? Because sometimes you have omental cake which is clearly more than 15 centimeters of size, and there is still not real large extent of other peritoneal infiltration.
Yeah, it's more the other way around. If it's less than 5 centimeters, the largest metastasis, the message of the EOTC study is you should do primary debulking. It's not because it's more than 5 that you should not do primary debulking. This mainly depends on the anatomical criteria.
Exactly.
So it's the other way around.
Thank you.
I sensed a slight difference in approach to, from an imaging point of view, Christina. And I just wonder whether it's something to explore, because I think you had a more formalized approach to preoperative imaging compared to what I understood from Christina's talk. And I just thought, is that something you could discuss?
We will discuss this afternoon. But
can I say something very, very quickly? I didn't say that we don't need to do preoperative imaging. On the contrary, I just wanted to point out how different countries approach this. And this, unfortunately, is based on the lack of absolute solid evidence currently. I was back then in Berlin this week, and I joined the tumor board they had, and most of the patients that would be operated didn't have a CT, and I was completely lost. I said, where is the tumor? What's happening with the upper abdomen? So it is definitely of value. However, it's very unfortunate that currently there are no real guidelines internationally where you say this patient has to have that or doesn't, and to rely on them. So it emphasizes the need of more trials. But we definitely need imaging. There is no question about that.
Yeah, well, my main point is try to get as good as imaging as possible, and 2, write it up. What is your criterion? What is for you inoperable? Because my criteria here, or our criteria, are not applicable to any other hospital, I think, because they are different from center to center. And that's, I think, why it's so important to agree with the people who are doing imaging, to give them your criteria and let them predict and check it.
You're absolutely right, and this problem will be in the trial that I showed you of comparing MRI, a preoperative MRI with CT in terms of operability. This is going to be a multi-center UK study where you have high-volume tumor centers that do ultra-radical surgery, and surgeons with centers that never strip per principle the diaphragm because they think it's not necessary to do it.
Yeah, but the
so
diaphragm is the easiest.
Exactly, so it's a massive,
Why should it be inoperable?
Exactly, so it's a massive issue in this trial.